Hi, everyone. Thank you so much for tuning in virtually today for this fireside chat with Zack of Ophelia and Evans Rochaste of ReKlame Health. I will let them introduce themselves momentarily. But first, I'm Anastassia Gliadkovskaya, a staff writer at Fierce Healthcare covering health equity. I'm really looking forward to this important conversation on DEA policies on telehealth prescribing. The Drug Enforcement Administration granted flexibilities for prescribing controlled substances remotely during the COVID-19 pandemic and the public health emergency, waiving a requirement that an in-person visit must first take place. Some providers and advocates have long argued that amid an ongoing shortage of mental health providers, such a mandate could restrict access to life-saving care. The American Telemedicine Association has argued that requiring an arbitrary one-time in-person evaluation won't effectively prevent abuse or drug diversion. So before we get started, I will let Zack and Evans introduce themselves.
Thanks, Anastassia. I'm Zack, founder and CEO of Ophelia Health. We are a virtual provider of opioid addiction treatment, focusing on reducing barriers to access for the 80% or so of people in this country struggling who can't get into care, and predominantly serving the Medicaid population.
I'm Evans Rochaste, founder and CEO of ReKlame Health. We're a tech-enabled behavioral health and addiction startup providing culturally competent psychiatric care, addiction care, and wraparound services to overlooked populations and young adults virtually and in person across New York, New Jersey, and Florida. We're on a mission to change the way that overlooked populations seek healthcare and their experience.
Wonderful. Thank you so much. So to start, it would be helpful if we could get a little bit into the origins of the Ryan 8 Hate Act and the accompanying congressional mandate, which the DEA has thus far not really delivered on, to create a special registration pathway for remote prescribing.
Yeah, so the Ryan Hate Act is a federal regulation that was passed in 2008 after an individual purchased painkillers online with an illegitimate prescription and died. And the original intent of the regulation was to ensure that patients had an established relationship with a provider and a legitimate prescription before being able to access controlled substances. And the definition of a patient-provider relationship at the time more or less started and ended with an in-person encounter. And so the effect of the regulation is that in order to prescribe any controlled substances, you must first have an in-person encounter with your patient. The landscape of telehealth providers has evolved quite a bit since then. It's become increasingly clear to many of us in the industry that you can develop a valid patient-provider relationship using telemedicine. But while telemedicine was called out in the original regulation, it was never defined. And it was sort of left open-ended how you might be able to establish that relationship without an in-person. In 2018, Congress passed the SUPPORT Act, specifically focused on increasing access to medication-assisted treatment for opioid use disorder, which is now the #1 cause of death for Americans under 50. And in particular, creating a special registration for providers of buprenorphine, which is a Schedule III substance, to be able to prescribe to patients without that in-person visit. And the DEA was given a deadline of October 2019 to define this special registration specifically for buprenorphine. They came out, asked for more time, and then of course COVID hit, everyone's priorities changed. What Ryan Hate Act was waived temporarily during the public health emergency, and people forgot about it. Well, several years later, the federal COVID public health emergency is gone, and the DEA had been asked to define once and for all what comes next. Their best attempt was an interim final rule earlier this year in March, where they came out with a proposal about a more flexible version of Ryan Hate, but one that would still require an in-person visit. They were faced with a lot of backlash, I think 30,000 plus comments from the community. They said, okay, give us 6 months to figure this out. They pushed the deadline until November of this year. And then in November of this, or right before November of this year, came out and said, we need more time. We're going to extend the flexibilities through 2024, but the plan is to define this special registration. So we're all wondering what the special registration will look like, who it will apply to, and critically what the details will be. And there's lots of lobbying going on right now to make sure that the requirements of the registration are not too onerous to prevent providers from effectively offering care, even if they're legally allowed to do so.
That's a really great overview. Thank you so much. Evans, go ahead.
Yeah, would love to piggyback on Zack. One thing about COVID-19 is we didn't expect it, right? It just came upon us, and during when this was happening, I mean, the most apparent thing to do was to see how can we expand flexibility to healthcare. So what we've seen with telehealth is that a lot of studies have shown that is just as effective as in-person care. And what the pause of the Ryan-Hyatt Act has allowed us to do is expand care into care deserts, is to expand care into populations who are more at risk, such as BIPOC, underrepresented populations. So, as a provider and clinician by training who has helped thousands of people take back control of their lives, some of the uncertainties of the Ryan-Hyatt Act and how we're going to move forward, and if there's a world where there are some added constraints that we have previously maybe let go of, such as the data X prescribing requirement, what will that look like, and how will that impact patient care, business models? So the Ryan-Hyatt Act is something that is really the intersection of policy and healthcare and humanity here and now.
Yeah, and I'm wondering, since we have gone through so many iterations of changes since the start of COVID with these telehealth flexibilities and these extensions and these proposed rules, all throughout that, has there been any interruption to your treatment or your services, your ability to serve these underserved populations?
There's been, at the core, there's been a lot of uncertainty, right? Around, hey, what are we going to be able to have visits with someone who needs a refill or needs to see their provider in 90 days, and what would that look like? So for us, we've had to remain really flexible with our business model and have levers in place that would allow us to continue to treat folks who are looking for care. An example would be investing in more in-person locations or presence, right, to be able to do that. But there hasn't been interruption, but there's been a lot of uncertainty as well as anxiety. We heard from a lot of our patients when uncertainty around the first or second wave of the Ryan-Hyatt Act or the telehealth regulations. Like, I don't know what I'm going to do. This is the only way I've been able to access my care. The nearest provider who can help me is 15 miles away. So that has been truly how we've been affected overall.
Yeah, there are different levels of disruption. Some are more material than others. So first of all, Ryan-Haight is a federal regulation. There are a handful of states that have their own version of an in-person visit requirement that supersedes Ryan-Haight, even if it were to be removed. And so some of these states have basically said, we're going to defer to the federal government. Others have said, we don't care what the federal government says. There's always going to be an in-person visit requirement in our state until we change it. But that level of uncertainty has required organizations like ours to focus on states where the laws are friendly and are likely to stay friendly as long as the federal government stays friendly. So the state level regulations are important to focus on as well. The second is, it's been a huge distraction. I mean, there were times during the public health emergency for COVID. By the way, there's an opioid public health emergency in effect and one that has been in effect for a long time. The waivers are not tied to the opioid public health emergency. They were tied to the COVID PHE, but the COVID PHE was being renewed every 3 months and often not until like the last minute. And so you can imagine an organization that's responsible for caring patients who are depending upon them for their life, not knowing what will happen on a Friday the following Monday and whether they will be legally allowed to continue treating these patients. That causes, as Evan said, a lot of anxiety, but also a lot of extra work that goes into planning for contingency in case things don't work out in our favor. The last piece, which Evan's also talked to, is the value of certainty in our industry. So there has been a tremendous amount of evidence supporting the value of telehealth, specifically for opioid addiction treatment, but also for other disorders. This research has been published by the federal government itself. But in order for this modality to survive long term, it needs to have the supporting infrastructure in the form of not just codified regulation, but also buy-in from payers. There needs to be an adequate reimbursement system to keep virtual providers offering care and doing so with reimbursement that covers that cost of care. But payers themselves are really not sure what to think about the future. And so if you want to accelerate innovation in this space and codify the status quo, it would be really helpful for the government to state what they're going to do, sort of like the Federal Reserve does with interest rates, so that everyone can actually start planning for real. Investors don't have to worry about whether or not this is temporary or permanent. Managed care organizations can start planning for the future, knowing that this is the future. And some level of certainty, irrespective of the details, would be hugely beneficial to the progress of the industry as a whole.
Yeah, that's a great point. And I mean, like you said, there is very clear literature supporting telemedicine and especially in the areas of substance use disorder treatment. Why do you think that it's taken this long for the DEA to, I get there's hesitancy around, history of pill mills and you want to be careful around prescribing and you want to be careful, but why do you think it's taken this long to get movement and some progress on exceptions for substance use disorder, buprenorphine, which we know it's really hard for people to access around the country?
I think, unfortunately, the short answer is that the DEA, who has had primary authority over this regulation, is an agency of attorneys, not physicians. And so the things that they are tasked with include preventing diversion of controlled substances, minimizing traffic of illegal substances, specifically across the border. They're not necessarily thinking about optimizing for patient health outcomes in the way that the American Society of Addiction Medicine would. Their mandate is to reduce diversion. And if they see this as a way to reduce diversion, they're going to approach it with tunnel vision because that is their mandate as an organization.
That makes sense.
Yeah.
Go ahead.
I agree with, thanks for sharing, Zach. Yeah, I mean, my perspective, just from an analytical standpoint, I think number one is we weren't really ready for this, right? And there's a lot that the DA had to process overnight, essentially, with COVID, even though it's been years and even though it's been a couple of years here and now. I do believe striking a balance around what is actually needed and effective for patient care based off of the literature, evidence-based care, health outcomes, versus mitigating risk around diversion may be a thought process that is happening. But like Zack said, if the number one cause of death right now for people under 50 is overdosing, is by overdose. And we know that for us, we laser focus on underrepresented populations, and Black and Hispanic populations, they tend to overdose by 4 to 6 times their counterparts, Caucasian people. So I think we have to look at impact life versus what can be the potential risk, because there's always going to be potential, like pros versus cons. But if we see 9 pros and we see lives that can be saved, I believe that this is a situation where Zack said we may want to move a little bit more swiftly, given that the impact is potentially people dying?
Yeah, I'll also, before we move on, call out that in my opinion, the project of preventing diversion has in all likelihood increased diversion of buprenorphine over the last decade. And the reason I say that is buprenorphine is not a medication that people take to get high. They take it to stem withdrawal when they're trying to stop using dangerous opioids that can kill them, like heroin, fentanyl, or oxycodone. And there is diversion of buprenorphine today, where patients will spend thousands of dollars to buy it on the black market. But the only reason they do that is because it's too difficult to get from legitimate medical providers. And the reason it's been too difficult to get from legitimate medical providers is because the DEA has put up lots of unnecessary barriers, including not just in-person visit requirements, but what was formerly known as the X waiver requirement, where you needed a special registration with the DEA as a provider in order to prescribe buprenorphine that only 5% of clinicians in this country had. So nobody wants to spend $1,000 for prescription medication on the black market that they could otherwise get for free with insurance if they have Medicaid through a provider. The only reason that there is diversion is that there is demand for diversion because it's too difficult to find alternatives. If you want to stop diversion, you can end demand for diverted buprenorphine by just making it easier to get from the medical professionals.
Yeah, that's a great.
I would, yeah, 100%, Zach. And 2019 or 2018, the rules used to be that starting out to prescribe, if you're a provider prescribing buprenorphine, number one, you had to get a Data X, which was hours and hours of training, and you can only actually provide care to 30 people active on the list. And if you went one person above that 30 person roster, you can find yourself in trouble. So, and then also there was a lot of fear around what could happen if I had 31 or 32 people on my roster. So thinking about that in general, right, and understand that only 5% of people held that special waiver, I do see that I do believe that we're still seeing the effects of some of the constraints that has historically been placed around the treatment of opioid use disorder, even now today.
Yeah. Well, thank you so much for those points. And you both spoke about how this is just a matter of public health experts and providers being on the front lines, working with these populations, understanding the urgency versus, policymakers that are pretty far removed from that reality, not really understanding how their decisions impact everyday care. And I wanted to ask, taking that into account, how can policymakers, how can providers or advocates communicate to policymakers the consequences and the ripple effect of such decisions? Obviously, they're not intentional, but if you've been involved in any advocacy work or you have seen powerful examples, can you share what tactics you think are effective in communicating that?
Yeah, I would say number one is collaboration and getting different stakeholders in the ecosystem aligned right around these big topics. Similar to healthcare, which is often being lived in silos, at the leadership level, or at the level where we think of the intersection between policy, government, and healthcare operators, clinicians, we're also often operating in silo. To Zach's point, if the DEA, if the primary workforce is with attorneys, then it would be great for us to, as operators, clinicians, really align or really collaborate to understand understand these big topics and big challenges, and how can we come to a census of what makes the most sense. We've seen that pick up around the mental health crisis, around challenges around Medicaid innovation, and more payers and states really starting to open up the dialogue together to approach challenges. But I wonder if we're maybe one step or two step behind when it comes to opioid use disorder and the challenges that arise around that. Zach, I'm curious your thoughts.
Yeah, first of all, I wish I had a good answer to your question because this is the relevant question. And the unfortunate reality is that it could not be clearer what the right thing to do is here, which is to deregulate evidence-based treatment and make sure that it is reimbursed at a level sufficient to incentivize providers to offer it. And we would not be in an opioid crisis anymore. I don't think that is terribly controversial among academics and policy experts. The question is, how does it become codified into law? And the answer to that question is the answer you'd get to any question related to overcoming political inertia, which usually comes down to what do the constituents care about? So if we can find a way to convince politicians that their ability to be elected depends upon them having rational views on litigation related to or regulation related to telehealth, then that would certainly be helpful. Having said that, there are many issues that Americans care about, and it's hard to know how you make this one top of mind, even if the government continues to say all right.
Yeah, that's very true. And I wanted to ask, in August, the DEA had said that it was open to considering a special registration pathway in its final rules. And it also said that it believes that in this new era of telemedicine, it is necessary to have additional compliance mandates for providers, like increased data collection, increased visibility into their prescription practices. I'm wondering, what sort of operational or administrative burden would such mandates put on providers like yourselves?
These are the critical questions, Anastassia. There are different levels of barriers that the government can impose upon providers who are trying to operate in good faith. Number one is by outlining things, saying you cannot treat this patient unless you do an in-person visit. Another is by adding sufficient administrative costs that it becomes a loss-making endeavor to try to do it without commensurate increase in reimbursement. And that is my fear. So today, we employ a pretty large care team whose responsibility it is to chop down red tape for patients that only exists because of things put in place by health insurance companies around prior authorizations, concerns by pharmacists that if they fill a telehealth prescription, the DEA will come after them. And if you put in place additional requirements that may potentially create a divide in, let's say, the mind of pharmacists between telehealth providers and what is perceived to be more legitimate in-person prescribers, there is a risk that you increase friction in the system and increase costs. And if there is no commensurate increase in reimbursement, you're going to see a scale back in access rather than the opposite.
Yeah, similar on the same foot. The one thing that we have seen, right, is increase in operation complexities, right? Being able to, our care navigator team, it's just probably 3 times the normal size of a care navigator team, just to help navigate with pharmacists, just to help patients who are on their journey trying to get their prescription but are facing barriers. And we have seen complex cases where someone is trying to get a prescription, but they're also potentially have a diagnosis of ADHD and they need that treated as well. So, and then there's trouble getting that prescription. So I think anything that increases like complexity, as well as we already have a supply chain issue when it comes to providers. We have a shortage of psychiatrists, a shortage of behavioral health providers, and there's already some anxiety around treating complex populations or diagnoses. So if we implement things or advance policy that adds more fear, like Zack said, we're going to have a cutback of access because providers, which is the primary workforce, will may not elect to continue to treat. So there's a lot of downstream effects that happen right away from some of these changes.
Yeah, I'll give one concrete example of unintended consequences that are playing out right now. So many of the big pharmacy chains have been held accountable for over dispensing opioids and precipitating the crisis that we're in right now. And they've been sued for lots of money, billions of dollars. At the time that they were dispensing these medications, it wasn't clear to many of them that they were in violation of the law, but standards in some cases have been applied retroactively that they couldn't have, at least in their defense, foreseen at the time. Well, what has happened? Walmart, one of the largest pharmacy chains in the country, has decided that it will not fill prescriptions for any telehealth provider, period. Regardless of what the federal government says is legal or illegal, because they're thinking about the future financial risk to the business of being penalized retroactively for things that they're doing now, which it turns out they shouldn't be doing, as determined by some future court authority. So the more you spook the industry, the less likely they're going to want to participate, and that's why this issue of transparency and permanence is critically important. Perhaps as important as the legislation itself is the DEA issuing very firm guidance to pharmacies that they're not going to be held accountable for filling prescriptions by legitimate providers who meet some basic requirements. And if they meet those basic requirements, it should not be black and white. And it should not be the pharmacies who are held accountable for trying to make discretionary judgments over who deserves or doesn't deserve to get the medication.
Yeah, if I could add a point to that. Yeah, that scenario impacted our operations significantly. We had three big chain pharmacies essentially overnight in the region say we're not filling any prescriptions from telehealth providers that was not aligned with state law or federal law. And what we had to do was look for mom and pop pharmacies, work with insurance companies, and that required just more staffing, more calls, patient frustration, confusion, just over the fear that these pharmacies had, as well as the pharmacists themselves, essentially fearing that if they did provide the support or if they did fill this prescription, that them as a medical provider would be held liable. That's a lot of fear to carry on for someone who has dedicated their life to help people.
Yeah. Those are all really great points and sad examples. And as you were talking, I was thinking about how this chilling effect applies to so many areas of healthcare, like women's healthcare, abortion, or gender affirming care, where there's kind of confusing or unclear or even non-mandatory recommendations put out by lawmakers, and it just confuses providers and pharmacists and all these stakeholders across the supply chain to the point where it actually becomes very difficult, if not impossible, to keep providing this care. And when we're thinking about complexity, I wanted to ask, in terms of continuity of care, Zack, you mentioned that state laws are something worth considering. Last year, Alabama implemented a law that basically requires an in-person exam for remote prescribing to have happened in the prior 12 months. And I had written about how Bicycle Health, which is another virtual provider for opioid use disorder, had to actually fly staff into the state before the deadline and see all the patients in the state so that they could keep continuing this care. This is obviously not something that's a feasible strategy for everyone. And, if more states come out with similar regulations, then it's just going to put a huge strain on the provider workforce. So how do you think about continuity of care in the midst of this uncertainty where certain states might be imposing new rules that are going to affect patients in that state?
So I think continuity of care is critically important, and I think it's the responsibility of the provider to make decisions that minimize risk for patients. I don't know the specifics of the situation in Alabama, but I would guess that there were clues ahead of time that Alabama might be putting a regulation in place or not passing a regulation to remove the requirement. I don't know, but I know that we as an organization decided not to be in Alabama in part for these reasons. And there is so on one side you have the risk of being a little bit too aggressive in your expansion and moving into states where the laws aren't all that certain, and then being caught in a situation where all of a sudden you can't continue to treat your patients unless you do extraordinary things. There's also the risk on the other side, which is that you remain too conservative and you don't treat patients in states that perhaps need it the most. And lots of states in this country that have the highest rates of overdose deaths are also the ones that have the most stringent laws against prescribing. And sadly, we are not able to operate in many of those states unless we're willing to take on, in my opinion, an intolerable level of risk for us and for our patients.
Yeah, building off Zack's what Zack added, it's problematic. I would point out one state that I went to Penn State, and so I spent a lot of time in Pennsylvania. And that state right now is struggling with the opioid epidemic, and from a regulatory standpoint, it's one of the most stringent states for providers to work in that state. When you look at what an NP requires just to work in that state, they would require 2 medical doctors. Reimbursement can be challenging. But we're seeing like the effects of what's happening in Philadelphia and greater Pennsylvania. So like Zack's point, when we think about the intersection of policy, state law, as well as some other programs such as Medicaid that can change state to state, and we're conducting risk analysis. There's some states where the business model doesn't become viable to be able to help, but we have people that need help. And for us, we really feel for those folks who are oftentimes don't have any other solutions, such as people who are living at the poverty level, underrepresented populations, where there's just nowhere to go.
Yeah, thank you so much for those points. Yeah, it's a difficult decision that a business has to make, especially when you're trying to serve already marginalized communities and trying to reach those that are the most underserved, like you said, in states that might just have too many complex regulations to operate there. But on a more positive note, just a few days ago, a group of senators introduced a bipartisan bill, the Telehealth Response for E-Prescribing Addiction Therapy Services, TREATS Act, with the goal of increasing access to telehealth services for substance use disorder. What are your thoughts on the TREATS Act, and are you hopeful that it's going to make headway in Congress?
So I think very highly of the TREATS Act. I hope the TREATS Act gets passed. However, I've been reading about the TREATS Act now for several years. So this is not, I know that it's news that it has been reintroduced, and maybe it will catch more traction this time, but I've hoped and been disappointed to see the TREATS Act in legislation now for at least 2 or 3 years. So hopefully this time is different.
Similar, I hope, with some of the progress and the dialogues we've been able to open up, that we're able to accelerate the passing of this act.
Great. And are there any, before we close, any last minute big ticket wish list items? If you had a magic wish that you could make any policy or regulation happen federally or at the state level that would help facilitate your work in the substance use disorder space, what would you say would be the most important, or a few of the most important things?
Yeah, my answer might not be that elaborate. I would say the number one wish would be, how can we expand access through telehealth and other means that we know that works, and as well as how can we ensure that we're following clinically back or clinical evidence that supports the need for treatment, that supports the route and mode of treatment, that we know that that works.
Yeah, I mean, from my perspective, there are several possible equilibria that are desirable for ending the opioid crisis. One of those is an environment in which there's lots of regulation, high administrative friction, but also high reimbursement to cover the cost of meeting those requirements. And in that environment, you get enough providers in the space offering care to enough patients that you don't have surging overdose deaths year by year. Another equilibrium is one in which there is no increase to reimbursement, but a relaxation of regulation so that the cost of providing care come down and the economics work out in favor of access. Right now, we're in between those two equilibria. So in my opinion, lots of the problems that you're referring to are solvable. They're solvable by having people on your team who can deal with them. So if you need to call 3 pharmacies in order to find one that will prescribe for or dispense to your patient, you need to do a prior authorization in order to make sure they can get their medication. You can solve that problem by employing somebody to do that job, as long as you can get reimbursed to cover the cost of care. So either remove those requirements or increase reimbursement. And the thing that scares me most is that the most vulnerable population is that which is covered by Medicaid. About half of people in this country who are struggling with opioid addiction are Medicaid, and Medicaid is managed at the state level. The federal government has limited jurisdiction over what state Medicaid programs decide to pay for or not pay for. And what I would like to see is some level of guidance in the federal government that is passed on to states in a way that makes it very easy and perhaps required to implement. So in 2020, the CMS introduced a new set of codes. These are bundled codes for telehealth-based medication-assisted treatment. And mind you, this was before the pandemic, so there really weren't very many providers. Yet this was introduced into the CMS fee schedule, but the CMS fee schedule is a Medicare fee schedule. Many commercial providers will adopt it, but no state Medicaid plan, to my knowledge, has adopted these codes. How do we get Medicaid offices to pay sufficiently for care such that enough providers are willing to do it? And at the end of the day, we're not asking for a net outlay of money. We know that treating patients for opioid addiction ends up saving the system money by virtue of reduced emergency department admissions. And therefore, expanding access will actually be expansionary to the Medicaid budget, not contractionary, as long as the government is willing to pay for what I'd call preventative care.
Wonderfully said. Well, thank you so much both for your time. This is a very important topic and it's evolving a lot day to day. So I'm really grateful for your insights, and I know that our listeners have learned a lot today too. So thank you so much.
Thank you so much.
Thank you.